Okay, now welcome back to the topic of neurocysticercosis. We'll continue the part 2, and in this part we'll talk about investigations. In part 1 we left CT. We left with the CT. We did everything about CT scans in neurocysticercosis. Now we are going to talk about MRI. So MRI is the imaging modality of choice for three things. If we are suspecting intraventricular and cisternal or subarachnoid cysts, if they are very small cysts which are hard to pick on CT, and if cystic degeneration and pericystic inflammatory reaction is suspected. And newer MRI techniques are used these days, which include the MRC technique or the magnetic resonant Cisternography or the fluid attenuated inversion recovery sequence, or what we call as FLAIR. Now in MRI also we have these four basic stages, which is vesicular stage, followed by a colloidal stage, followed by a granular stage, and followed by a calcified stage. You can just take a shot of this screenshot of this table, and if it helps you, you do remember it by heart. If it does not help you, then just leave it. This is more of a radiologist kind of a thing. Okay, this is neurocysticercosis in FLAIR, in T1 weighted image, in T2 weighted image, and FLAIR sequence. Now let's talk about the differences, or which is preferred when. So now CT versus MRI. MRI is preferred in situations when there are small lesions, when there are cisternal cysts in brainstem or interventricular lesions are present. MRI is preferred when we have to see the scolex inside the cavity in the brain parenchyma. Again, MRI is preferred when we have perilesional edema around the calcific lesion and degenerative changes in the parasite. For all of these, MRI is the preferred choice of modality. Now CT scan is preferred because it is cheaper. Yes, of course, it is cheaper and it takes less of time. Small areas of calcifications can be seen with CT, and the cystic circle infestation of extraocular muscles can also be seen on CT. So the dictum or the rule of thumb is perform CT scan followed by MRI in the patients with non-conclusive findings or those with negative CT scans where we have a strong clinical suspicion of neurocysticercosis. So we proceed as we do a CT, and if the suspicion is still there and CT images are not giving a clear clue about the neurocysticercosis, then we proceed with MRI as a modality of choice. This is a very nice image, MRI image of lateral ventricles showing the cyst with the resultant hydrocephalus. You can see the ventricles are dilated. Again, the CT image which shows multiple intracranial lesions. Multiple. This is what we call as starry sky appearance. Then we have CT cisternography, which you can see. This is a very rare investigation, not used that much in cases of neurocysticercosis. It is mostly used when the MRI is contraindicated or we cannot perform MRI because of some reason. This is MRI angiography, and you can see a very nice view of, you can get a nice view of occlusion over here. Let's talk about biopsy. Now biopsy of subcutaneous nodule or muscle of lesion is a good way to demonstrate the organism and is definitely most diagnostic of cysticercosis. Ultrasonography. Ultrasound or ultrasonography is useful especially in diagnosis of ocular neurocysticercosis. The cysts are well delineated when they occur in a subretinal location. Remember, we talked about during the pathogenesis of this disease, I told you that whenever you have a patient who is suspected to have neurocysticercosis, you definitely get a fundal exam or an ophthal consult done for that patient. And if you have subretinal location cyst, or you have an organism which you suspect is present in subretinal location, then you do not treat the patient with anti-parasite drugs. You do not treat the patient with anti-parasite drugs. That is the rule of thumb. You always put the patient on steroids. The max you can do is you can put the patient on steroids. You never put them on anti-parasitic agents, because that will cause degradation of the organism, and that will lead to severe inflammatory response, which will then lead to retinal damage or injury, which will be permanent, and the patient will be blind. So that is very important thing to remember. So the cyst wall is well depicted against the vitreous humor, and the cyst elevates the retina. So the cyst actually elevates the retina. If this is the normal retina, because the cyst is present over here, so it will elevate the retinal surface. That is why it is called subretinal. It is under the retina, Drawbacks are, it is user dependent. So it depends on the expertise of the person who is performing the ultrasound scan on the eyeball. A cyst without a scolex cannot be differentiated from other cystic lesions of the eye. So to make a differential diagnosis is sometimes difficult when the scolex is not visible or cannot be visualized. Brain biopsy, not done in that much of cases. It is very, very rarely done, and that too only in the extreme cases. So it is better a trial of anti-cysticercal drugs followed up imaging shortly thereafter, like 2 months, is recommended before considering biopsy, because it is very, very dangerous. Brain biopsy is not an easy job to do. Lots of risks are associated with it. So the histological features on biopsy. A cysticercus is a liquid-filled vesicle with a three-layered wall and a scolex. Although the scolex is not found in all the cases, but most of the times it can be seen. The parasite can adopt 3 different presentations on a biopsy. So it can attain a cystic form, a racemose form, and a mixed form. So what is a cystic form? Cystic form is approximately 7 millimeters in diameter and may be single or multiple. Frequent locations are leptomeninges and cerebral cortex. These are the 2 frequent locations where the cystic form is found. The racemose form, racemose as from the name means the bunch of grapes. So it has multiple cysts in basal cisterns. Mostly the most predilected location is basal cistern. We know this by now. They do not have a scolex. Most of the cases do not have a scolex in racemose form, and because of their location, the racemose form can produce, because it is present mostly in the basal cistern, so it will block the outflow of CSF in the basal cistern, and it will cause hydrocephalus. Sometimes they give impression of an infiltrative aspect called Trillis canceriform presentation. The name is important, Trillis canceriform. Whenever it gives an impression of infiltrative aspect, we call it Trillis canceriform presentation. Mixed form can present as both racemose and cystic forms. Now let's be talking about the diagnostic criteria. So in neurocysticercosis, we use a diagnostic criteria by the name of Del Brutto diagnostic criteria. So we have 4 basic considerations in the criteria. One is absolute criteria, one is major criteria, then we have minor criteria, then we have epidemiological criteria. What in diagnostic criteria? For the diagnostic criteria, we have 3 things. Firstly, the biopsy of the brain or spinal cord lesion should be diagnostic. Then secondly, cystic lesion with scolex on CT or MRI is visualized, means imaging modality should be able to visualize cystic lesion with scolex. Thirdly, the fundoscopic examination should have or should give us subretinal parasites or subretinal organisms. In the major criteria, we have 4 things. Firstly is highly suggestive lesions on neuroimaging. Then we have positive serum electroimmunotransfer blot testing. Then we have resolution of intracranial cysts after therapy and spontaneous resolution of small single enhancing lesions. In the minor criteria, we have compatible lesions on neuroimaging. See, in major criteria we have highly suggestive lesions on neuroimaging, but in minor criteria we have compatible lesions on neuroimaging which look like they are neurocysticercosis, but we are not sure. That is why it is a minor criteria. Clinical manifestations suggestive for neurocysticercosis, which can include altered sensorium, which can include vertigo, which can include vomiting, headache, fever, and so on and so forth, depending on the localization of the cyst in the brain parenchyma. Thirdly, the positive CSF ELISA for specific antigen or antibody. And thirdly, cysticercosis outside CNS. It can be in muscles. So we have to look for it. The epidemiological criteria for neurocysticercosis in Del Bluto diagnostic criteria is evidence of household contact with Taenia solium or the pig tapeworm, individuals coming from living in endemic areas, and history of frequent travel to endemic area. So how do we say whether it is diagnostic or not? So degrees of diagnostic certainty depend upon, if for definitive diagnosis we have to have one absolute criteria. For definitive diagnosis we have to have one absolute criteria. For the other criteria for definitive diagnosis is we have two major, one minor, and one epidemiological criteria. So two major criteria, one minor criteria, and one epidemiological criteria, and these will give us definitive diagnosis. For probable diagnosis, there can be presence of one major, two minor, or one major, one minor, and one epidemiological criteria, or presence of three minor and one epidemiological criteria. Now let's talk about what we do in case of enhancing lesions or degenerating cysts. If it is mild to moderate or mild or moderate, no antiparasitic treatment is required, just neuroimaging on follow-up. We can also give antiparasitic treatment and steroids depending on the condition of the patient or clinical presentation, and we can try antiparasitic treatment and steroids if only side effects develop. Okay. In case of heavy cysterosclerotic encephalitis, no antiparasitic treatment is given, only high dose of steroids and osmotic diuretics are given, which is mannitol or glycerol. Then in case of calcified cysticerci, any number, no matter what, no antiparasitic treatment is given. In case of extraparenchymal neurocysticercosis, if there is ventricular cysticercosis, then we do neuroendoscopic removal if it is available, of course. In case of subarachnoid cysts, including giant cysts, grape-like or racemose cysticercosis, or chronic meningitis, we give antiparasitic treatment plus steroids. And if hydrocephalus develops, we do ventricular shunting. This means surgery. Hydrocephalus with no visible cysts or neuroimaging, we do ventricular shunting and no antiparasitic treatment. It's again surgery. So these are the indications when we require surgical approach. In extracranial cases, when we have spinal cysticercosis, the primary care is surgical. Okay, and there are some reports also of successful use of albendazole with steroids, but mostly it's surgical. Ophthalmic cysticercosis, again, it's surgical resection of the cysts, because we know in ophthalmic cysticercosis, if we give treatment, we are going to lose vision of the patient. Now, the anticonvulsants or the supportive therapy. Anticonvulsants are to be given to the patients who present to you with seizure or seizure episodes. The first seizure due to inflamed cysticercal lesions should be considered always as acute symptomatic seizure and should be treated only for the duration of acute condition. Okay, and the treatment is to be continued, during which the inflammatory response is active, which might sometimes last up to some months in some patients. And it should be stopped after the resolution. And there is a very important question, when to stop antiepileptics. So basically the rule of thumb or the dictum is, mostly in clinical scenario, when the patient is having no seizures for about 1 year, no seizures for about 1 year, we try to taper off antiepileptics, and we often stop them after 1 year of seizure-free interval or period. And the thing to remember is that longer durations of antiepileptic treatment are needed for those patients who have persistent or calcified lesions. This is something we have to. So when to follow up? So we have to follow up the patients with imaging study, and it is recommended like in 2 to 3 months we have a imaging study done again, and that's how we follow the patient, and that's how we look at the cysts. The use of imaging will always guide the requirement for like future treatments or future requirements, be it the drug therapy, be it the surgical indications. So we have to be cautious. What about the treatment of extraneural cysticercosis? We do not treat extraneural cysticercosis if the patient is asymptomatic. Surgical excision is required for intraocular disease. Medical therapy for involvement of extraocular muscles or optic nerve if required. NSAIDs are used for patients with symptomatic subcutaneous or intramuscular lesions, and excision of solitary lesions if NSAIDs fail or not tolerated by the patient. Now, what is the prognosis? In most of the cases, in clinical scenarios, the prognosis is good. Seizure definitely seem to improve. The patient is definitely getting better after the treatment with the anti-cysticercal drugs. The racemose form is very often associated with poor prognosis and elevated mortality rate, which can be reaching up to 20% or even more. And 22% of the patients with racemose cysts have recurrent seizures. Other patient symptoms can include headaches, neurological deficits related to strokes, and hydrocephalus. The patients with the complications such as hydrocephalus, multiple lesions, and large cysts with perilesional edema and chronic meningitis along with vasculitis sometimes do not respond to treatment that well. So what can we do for prevention? Very nice image, I must say. See some number of cysts present. What about human tapeworm infections or infestations? The inspection of pork for cysticerca is very important. Freezing or adequately cooking the meat to destroy the cysticerca is very important. Administrating anti-parasite agents to the pigs. Infection in the pigs, confining animals and not allowing them to roam freely. That is how they get it from the vegetation via eggs. We have talked about earlier in part 1 in the life cycle of Taenia solium or the pig tapeworm. We have to improve the sanitary conditions, definitely. Egg transmissions to humans can be controlled by good personal hygiene and hand washing prior to food preparation, identifying human carriers of tapeworms, and mass community programs to treat the tapeworm carriers. It can be via giving them albendazole. Possible vaccine. Porcine vaccine is currently in the works. Let's see how it works out in the future. Let's talk about conclusion. Neurocysticercosis is a major cause of epileptic seizures. We know by now. In developing countries, 29% of the seizure patients have neurocysticercosis as the primary cause of seizures in the developing nations. Varied clinical presentations preclude clinical diagnosis in most cases and demand imaging. Neuroimaging is very much required in most of the cases. Now, amidst the controversies, treatment of neurocysticercosis is still dubious, which is the least to say. Neurocysticercosis is potentially eradicable. It is very much preventable and eradicable. Early diagnosis and individual case-based treatment and community measures for prevention remain the cornerstone of the disease management. So it is very much required at the community level that people should understand and get themselves or the carriers treated. Thank you so much for tuning into the video. Hope you like it. Hope you get some knowledge out of this. Hope it helps you. I have tried my level best to make this as simple as I can. We'll very soon meet in another video with another topic, and if you want some specific topics to be covered by me in these video sessions like these, please do let me know in the comment section. Please share, like and subscribe. We'll catch you soon. Bye bye for now. Take care, stay healthy, stay safe. May God bless you.